So, hello everyone. So, today we will have our video meeting, and Dr. Hoffman will host the meeting and moderate the discussion. Thank you for coming.
Assalamu alaikum wa rahmatullah. Thank you everyone for attending our session today. I would like also to thank Dr. Nadir for his supervision for this great work. Our agenda today will start initially by talking about perioperative management of geriatric patient, and this will be the mission of Dr. Amal and Dr. Hajer. Later on, we'll talk about how to write a letter to the editor, and the presenter will be Dr. Shayma. The third mission will be about using Zotero for reference management. This is a nice program for referencing. The fourth thing is talking about how to use Google Sheets, an extension for analysis, and this will be presented by Dr. Nuha or Dr. Shayma, sorry. The last thing, inshallah, we'll talk about the project updates, okay? So let us start by the first presentation, which is about the perioperative management, and I will let Dr. Amal to start with you. Okay, Dr. Amal.
Thank you so much, Dr. Fath Rahman. Hello, everyone. Please allow me to share my screen.
Go ahead.
Yes.
Can everybody see my screen?
Yes.
Yes, Dr. Amal.
Okay. Okay, thank you, Dr. Fath Rahman. Hello, everyone. Thank you so much for attending, and I really hope that you will learn and enjoy our presentations for today. My name is Amal, and I'm going to talk about the perioperative assessment of the geriatric surgical patient. My colleague Hajar and I will be presenting this topic. So when you take care of a perioperative geriatric patient, you should never treat him like a younger patient, because older patients have specific requirements that young people usually don't have. Can you see my screen?
No, Dr. Amal. No.
Okay, I will share it again, sorry. Okay, these are my resources for this lecture. So because these older patients have specific requirements, the American College of Surgeons partnered with the American Geriatric Society and the John A. Hartford Foundation in 2012 to develop the American College of Surgeons National Surgical Quality Improvement Program in order to perform the optimal preoperative assessment of the geriatric surgical patients. So this slide represents the demographics of the US population. And as you can see in the first paragraph, back in the 2000s, ages 45 to 49 represents the majority of the population. In the second paragraph, in year 2025, as these young to middle-aged people are aging, the population curve is squaring, and now we have more people who are older. Now look at the last 2050 curve. Look at those 85 and older. These are becoming the fastest growing population in the next years. Given that more than 55% of all surgeries are performed for people aged 65 and older, it means that as the population ages, the number of surgeries is also going to increase. So our objectives by the end of this lecture are to be able to describe the following. The first one, how age-related physiologic changes influence perioperative care. and what makes a patient at risk for developing cardiovascular, pulmonary, renal, and neurologic complications, how to avoid iatrogenic complications, to describe basic elements of post-operative care, and finally, we are going to discuss the perioperative management of selected medical cases, like how to manage a diabetic patient before and after surgery. Here are some examples on how age-related changes influence perioperative care. For example, cardiac and vascular stiffening, which occur in normal people as a result of aging, may increase the risk of fluid overload. Decreased thermoregulation increases the risk of perioperative hypothermia. Stiffening of the thoracic cage and diminished ciliary function decreases pulmonary reserve and puts older patients at increased risk of post-operative complications. These include pneumonia and atelectasis in comparison to a younger patient. So pharmacokinetics are also different in the elderly. For example, as patients age, their body fat increases relative to water content, and this may decrease the clearance of lipid-soluble drugs, increasing their toxicity. Decreased kidney function, hepatic flow, and hepatic enzyme activity are other factors that can affect pharmacokinetics of drugs. So this slide emphasizes the fact that perioperative care should be individualized. It's not only a checklist that physicians go through, it's about addressing different problems for different patients. For example, most older people have one or more chronic conditions that influence perioperative care, either directly or through drugs. And even within an individual, organ systems don't age at the same rate. For these reasons, elderly patients require thorough and individualized preoperative care and often benefit from a multidisciplinary team approach. So one of the most important aspects of preoperative care is the surgical decision-making process. This slide highlights the important aspects regarding decision-making. So the healthcare team, including geriatricians, surgeons, and anesthesiologists, should ensure that they discuss personal goals and preferences prior to surgery. Some surgical outcomes like post-operative functional decline, loss of independence, and skilled care burden specifically affects the geriatric population and are very important to discuss. The healthcare team should ensure that older adult patients undergoing surgery have an advance directive in the form of a living will or a durable power of attorney, and a designated healthcare proxy or surrogate decision maker. Whenever possible, the healthcare team should consider early post-operative palliative care consultation in older patients with poor prognosis undergoing surgery, especially those not expected to survive more than 6 months post-operatively. History, physical exam, and lab investigations are definitely done for any patient undergoing surgery. But for the elderly, we should know something about their cognition, for example. Do they have the capacity to undergo surgery? Are they depressed? Because depressed people do poorly in rehabilitation post-surgery. Maybe we should put them on antidepressants prior to surgery. What about delirium? Substantial number of perioperative patients have delirium, and risk factors for delirium, like volume loss, for example, should be identified and corrected. Substance abuse, are they the type of patients who uses pain medications a lot? Are they alcoholic? It's very important to know these informations. What is the risk of perioperative myocardial infarction, and what is the risk of pulmonary and renal complications? Functional status and fall risks. And frailty. So frailty is a common geriatric syndrome that increases the risk of catastrophic decline in health and function among older adults. And there are some scoring systems to estimate the baseline frailty, which gives an important information regarding the patient's tolerability for surgery. Nutritional status is very important to assess as well. And social support, it's very important to know who's taking care of the patient at home before discharging from the hospital. We also have to do some specific diagnostic tests. Now let's move on to what is making patients at risk for developing adverse cardiac events. So the major adverse cardiac events that can develop post-operatively include perioperative myocardial infarction, heart failure, ventricular fibrillation, cardiac arrest, complete heart block, and even sudden cardiac death. This is a long list of surgeries that can lead to major adverse cardiac events. The point of this slide is that not all surgical procedures carry the same risk. Some surgical procedures are low risk at less than 1%, some are intermediate at 1 to 5%, and some carry a high risk of more than 5%. And as you know, surgeries like appendectomy and cholecystectomy can be performed laparoscopically or through the open approach. But when you are assessing the patient, you should always assume that they are going for the open surgery because you never know what the patient is going to choose, and you also never know the course of the surgery. The patient might choose the laparoscopic approach, but for a specific reason that the surgeon inside the operating room could not perform the laparoscopic approach, for example, because the patient is obese and had to convert to the open approach. So what type of patients are more likely to develop major adverse cardiac events or the MACE? The first group of patients are the coronary artery disease patients. History of myocardial infarction is predictive of MACE, which are the major adverse cardiac events. So try to delay surgery at least 60 days after myocardial infarction. It's not always possible if the surgery is urgent, but try to delay it at least a couple of months. Second group, patients with heart failure, you may need to delay surgery if the patient is decompensated. The third group, patients who have cardiomyopathy. So each type of cardiomyopathy is different and has specific needs. For example, patients with restrictive cardiomyopathy are preload dependent, and fluid needs are different for these patients. The fourth group, patients with valvular heart disease. Left-sided valves are more problematic than the right-sided valve problems, and stenosis is more problematic than regurgitation. As a general rule, patients with valvular heart disease cannot tolerate hypertension, tachycardia, volume shifts, and excessive administration of IV fluids. And sometimes you have to tell the surgeon about these issues. The most difficult valve disease to deal with is mitral stenosis because these patients are extremely preload dependent and they may not tolerate atrial fibrillation, which is a common complication of surgery. There are several risk assessment models that are used to calculate cardiovascular risk prior to surgery. And these are some links, like the American Heart Association guidelines. So are echo and ECG routinely done for any preoperative patient? Preoperative echo and ECG are not usually done as routine tests. For example, ECG is done for patients with non-coronary artery disease, significant arrhythmia, peripheral artery disease as a baseline for comparing post-operative cardiac complications. Echo is done for patients with specific cardiovascular examination findings like raised jugular venous pressure and S3 gallop. That is why history and physical examination are very important and usually sufficient to determine the need for these tests. So let's move on to the cessation of anticoagulation before surgery. The general rule is to weigh the risks against benefits, the risks of bleeding against the benefits of thrombosis. And in some minor surgeries like dental extraction, cataract surgery, we don't have to stop anticoagulation. So we all know the importance of dual antiplatelet therapy or DAPT in the prevention of stent thrombosis in patients with coronary stents. What we do in these cases is to weigh risks against benefits, as I said before. For bare metal stents, DAPT should not be stopped less than 30 days after its initiation. And for drug-eluting stents, DAPT should not be stopped less than 6 months. In case of urgent surgeries, DAPT may not be stopped, or sometimes interventional cardiologists are consulted because they are experts in the stents, and they know when to stop DAPT without major adverse cardiac events. So DAPT are usually stopped 5 to 7 days prior to surgery. For most patients, we don't use bridging anticoagulation therapy to reduce the risk of thromboembolism during the interval without anticoagulation, because in many studies, this is found to increase the bleeding risk. So I'm going to talk about briefly about the risk factors for perioperative pulmonary complications. So atelectasis, pneumonia, and prolonged mechanical ventilation are the most common perioperative pulmonary complications and are much more common in older adults than younger patients. Risk factors associated with increased risk of the above complications are categorized to preoperative, like age and smoking, intraoperative, like the type of surgical incision. You know that some surgical incisions are associated with increased risk of pulmonary complications, like the subcostal incision for cholecystectomy, for example, or type of anesthesia, and post-operative, like inadequate pain control and immobilization. All these factors might decrease ventilation, predisposing to ventricular collapse, to alveolar collapse, which can predispose to pneumonia and atelectasis. This slide summarizes the 2007 guidelines on the assessment of perioperative pulmonary complications. So risk factors for these complications should be appraised according to the guidelines. Chest X-ray and spirometry are not performed routinely for every patient. For example, chest X-ray is done for high-risk patients, like cardiac patients undergoing surgeries like abdominal aortic aneurysm repair. And post-operative lung expansion therapy is very important. The best measure to prevent post-operative pulmonary complications is incentive spirometry. This is a picture for the incentive spirometer. The patient takes in a deep breath and then exhales forcefully into the mouthpiece attached to the device. This helps in improving ventilation and preventing alveolar collapse, thereby decreasing post-operative pulmonary complications. Avoiding iatrogenic complications. Encourage time out of bed and avoid restraints. Early consultation of a physical and occupational therapist may be reasonable. Remove indwelling catheters as soon as possible to reduce the risk of infection. And the most important measure to reduce catheter-associated UTI is to remove the catheter when it is not needed. So you have to do frequent assessments and assess the patient's need for the catheter. Stop IV fluids and lift restrictions on diet as soon as possible, and review medications regularly. Okay, I'm going to stop here. Thank you so much for your attention. My colleague Hajar is going to discuss post-operative care and some special situations. Go ahead, Hajar, whenever you are ready. Thank you so much.
Thank you, Dr. Amal. Thank you, Dr. Fatah Rahman. And special thank you to Dr. Nadir for allowing and giving us this opportunity to participate in this research program. Okay, I will share my screen. Okay, are you able to see?
Yes.
Okay, I will present the second part of this topic about post-operative care and perioperative management of selected medical conditions. First of all, I will focus on most common post-operative complication in elderly. This is a checklist to facilitate comprehensive evaluation on daily basis. As my colleague Emma said, every patient should have individualized assessment, but as general, those are the most common. First of all, we have delirium. Delirium is the most massively significant post-operative complication. It is associated with all other major complications. We will talk about delirium later on. Perioperative acute pain, how to manage pain post-operatively, and pulmonary complication, as my colleague Amal talk about it, fall risk, ability to maintain adequate nutrition. Nutrition represent like 38% of hospitalized elderly patients are malnourished. Studies show that there is a relation between decreased albumin level in those elderly patients and increase the risk of readmission, mortality, infection, and pressure ulcers also. Even it increase the risk of prolongation of hospital stay. So we have to give supplementation, we give early enteral feeding as early as possible after the operation, and use supplementation. And if the elderly patient also use denture, make it available for him as early as possible. Urinary tract infection also, try to remove the catheter as early and as possible, and also do hygiene before insertion of the catheter. Functional decline is also associated with post-operative period. 30% of elderly develop functional decline after surgery, maybe due to advanced age or due to depression or cognitive impairment, or if there is comorbidities. For management can be put them in supporting programs, or family surrounding also may help, and multidisciplinary round by the staff also. Pressure ulcers, also one of the complications. We can reduce that by minimizing pressure or frictions, adequate nutrition, and wound care. Okay, delirium. Delirium considered a medical emergency because it leads to acute brain damage or acute brain illness. Maybe the only sign, delirium may be the only sign of acute illness, especially in elderly patients with pre-existing cognitive impairment. Non-pharmacological agent is always the first line treatment for delirium. If the patient is severely agitated and delirious and threatening harm to himself or to the others, lowest effective dose of antipsychotic can be used. This is a long list of pre-operative and post-operative risk factor for delirium. As my colleague Amal said, some example of them like malnutrition, surgical stress, infection, myocardial infarction, medications use, if I use more than 3, and even use of bladder catheter can precipitate delirium in elderly patients. How to prevent it? When pre-operative risk factors are present, clinicians should be especially vigilant about reducing sleep interruption, reducing dehydration, encourage mobility, avoid restraints, enhance sensory input, minimize medication, and controlling pain, constipation, correct electrolyte. Even the co-patient and the family, the one responsible for the patient should be like a familiar environment. One patient should take care, one co-patient which should take care of the patient. Okay, post-operative cognitive dysfunction. This is a transient cerebral dysfunction, but can be transient cerebral dysfunction. It is distinct from delirium in that here there is learning and memory loss. Post-operative cognitive dysfunction. It is transient, but can persist in 10 to 30% of patients. Most common after cardiac surgery, but it is not demonstrated to be linked to hypotension, hypoxemia, or even the type of anesthesia. Treatment for post-operative cognitive dysfunction is supportive. Post-operative care pain. One of the goals of analgesia control in elderly is to minimize the dose. The most important things for the elderly is to use the minimum effective dose and for the shortest period of time, especially for opioids because of the side effects. Well, for this reason, we have some opioid sparing techniques, for example, scheduling the dose of acetaminophen, give frequent doses, not exceed 4 grams per day with narcotic analgesia as needed, if able to request them, if the patient is able to request them. Multimodal analgesia control also can be used, like using different kinds of medications. And the goal is to reduce the dose and at the same time use different kinds of anesthesia instead of using one and increase the dose. For cognitively intact patients, consider patient control anesthesia like bump to improve pain relief and lower use of opioid, for example, epidural anesthesia. There is other useful adjuncts like ice packs, heating baths, massage, relaxation techniques. Always avoid NSAIDs in elderly because of potential GI bleeding, delirium, fluid retention, nephrotoxicity, and cardiovascular risk factors. Okay, post-operative care pain, continuing. Most post-surgical pain require opioid analgesia. Highest risk of under-treatment of pain occur in oldest old patient and on cognitively impaired patient. Patient unable to communicate effectively, standing order for narcotic analgesia with guidelines as to when withhold and with frequent assessment of medication side effect. So patient unable to communicate, give them narcotic analgesia. Opioid analgesia may precipitate constipation as a side effect. So we have to prescribe laxative and a stool softener with them. As we said, we have to give the lowest effective dose for the shortest time necessary. When the patient discharged home with opioid analgesia, you should give prescription naloxone with instruction for its use. Naloxone is opioid antagonist. Okay, this is fall risk and prevention. Fall is also very common in the post-operative and perioperative period. Most common causes are altered mental status, maybe due to delirium or medication side effect. So we have to manage delirium. Dehydration, one of the causes of fall risk, increase the fall risk. We have to hydrate the patient, frequent toileting. We have to schedule toileting for the patient. Patient with the previous history of falls also can increase risk of fall again. We have to check maybe there is history of osteoporosis or the environment is not good for them. Patient with impaired gait, we have to do physiotherapy or occupational therapy. Medications, side effect might also precipitate fall. Visual impairment, or auditory impairment, we have to provide them with their eyeglasses. There is general precautions like the environment and the bed in the hospital, hand trails, use of hand trails in the bathroom, and so on. Okay, this is the second part of this presentation about perioperative management of selected medical conditions. First, hypertension. Whenever the patient develops hypertension post-operatively, I have to check first for non-cardiovascular causes for hypertension. Maybe there is pain or urinary retention. I check for volume status, assess volume status, review fluid administration, and check if this patient omitted, if there is any antihypertensive being omitted. And even if the patient is the NPO, I can use parenteral antihypertension. It is available, ACE inhibitor, beta blocker, calcium channel, all of them are available in parenteral. Also, we can use topical agents such as topical nitroglycerin, which may be useful post-operatively if the patient is unable to take oral medication. This is like ointment or cream applied topically on the patient hand or trunk. Okay, so other complication may occur post-operatively, supraventricular or pre-operatively. Supraventricular tachycardia. Supraventricular tachycardia associated with if the patient have history of prior supraventricular arrhythmia, history of asthma, history of heart failure, or premature atrial complexes on a preoperative ECG. It is common in vascular surgery, abdominal surgery, and thoracic surgery. So the management will be try to restore sinus rhythm, at least control the ventricular rate by infusing adenosine, beta blocker, or calcium channel blockers. Treatment of atrial fibrillation post-operatively, if the patient is unstable and there is low risk of thromboembolism, cardioversion, electrical cardioversion. Atrial fibrillation post-operatively, spontaneous resolution, most commonly occur within 6 weeks after surgery. If atrial fibrillation persists 24 to 48 hours after surgery, I have to consider anticoagulation to reduce the risk of stroke. Heart failure complication, post-operative complication. Heart failure may develop as a result of excessive fluid administration or new cardiac ischemia or arrhythmia. Measurement of intracardiac pressure, ventricular filling pressure, by basing the assessment of volume status and physical examination, standard labs alone is very difficult and extremely challenging. I can use pulmonary artery catheter only in high-risk patients, although authorities advise against this approach. Post-operative kidney damage. Early signs of post-operative kidney damage like oliguria, increased serum creatinine. The mechanism could be pre-renal, renal, or post-renal. In pre-renal, signaled by urine sodium less than 20 milliequivalent necrosis. Serum urine sodium more than 40, urine sodium more than 40 milliequivalent per liter, because the kidney is unable to concentrate urine, so the patient will lose sodium in urine. Blood urea creatinine ratio 10 to 15 to 1. Urine sediment may have granular or epithelial cell cast. Obstructive nephropathy, especially in men with benign prostatic hyperplasia, bladder typically distended and palpable. This is the cause or the mechanism of kidney damage perioperatively. How to manage that? Acute tubular necrosis, hold all potentially nephrotoxic medication, and meticulously maintain an euvolemic state. Obstructive nephropathy, insert a bladder catheter to reduce the risk of hydronephrosis and improve kidney function. Post-operative gastrointestinal concern, we have constipation and diarrhea. Constipation, we have to order laxative or stool softener after ordering opioid analgesia, and consider suggesting prune juice, applesauce for the patient. For diarrhea, we have to check for Clostridium difficile toxin. Focus carefully on volume resuscitation in diarrhea patient. Okay, management of diabetic perioperatively. First, we have oral drugs are usually held we have to hold all oral medications, especially metformin, because theoretically it increases the risk of metabolic acidosis. Regarding glucose management, we have to give how to manage glucose during periods of prolonged fasting. We have to give intravenous glucose containing solution at a constant rate. On the same time, we have to administer subcutaneous insulin as needed to avoid severe hyperglycemia until the patient resumes eating. Many type 2 diabetic patients will be fasting for less than 1 day. If the patient is fasting for 1 day, then less day, he can be safely managed with withholding only long-acting diabetic agent. We can treat him with hyperglycemia. We can treat his hyperglycemia with short-acting insulin only. Vigilance is important. Diabetic patients are substantial risk for both hyper and hypoglycemia in the perioperative time. Okay, insulin using patient with type 2 diabetes, we have on the day of the surgery, on the first day of eating by mouth, and then we have when the patient can consume usual diet. On the day of surgery, we have to hold all the outpatient dose of insulin and put the patient on a sliding scale, in which we do insulin. We give only insulin as needed. On the first day of eating by mouth, a general rule is to give half of the outpatient dose of diabetes drug with a sliding scale insulin as needed. We will give half the dose of the diabetic drug. When the patient consumes a usual diet, resume full dose of diabetic drugs. Management of steroid. Patient on steroid. Perioperative administration of stress dose of steroid is appropriate for whom we will give stress dose of steroid patient on prednisolone more than 20 milligrams per day for more than 1 week, and patients with non-adrenal insufficiency. But if the hypothalamic pituitary adrenal axis function in question, the patient is not known to be adrenal insufficiency, but his axis in question, we have to measure his cortisol. If the cortisol is not elevated, we have to do consider a 30-minute ACTH stimulation test to check for adrenal insufficiency. Okay, we have recommendations here. Do not perform stress cardiac imaging or advanced non-invasive imaging as a pre-operative assessment in patient scheduled to undergo low-risk non-cardiac surgery. If it is not low-risk non-cardiac, we don't have to do the stress cardiac imaging or advanced non-invasive imaging. Patients who have no cardiac history and good functional status do not require pre-operative stress tests before non-cardiac thoracic surgery. Do not perform pre-operative medical tests for eye surgery unless there are specific medical conditions or specific medical indication. Avoid echocardiograms for pre-operative perioperative assessment of patient with no history or symptoms of heart disease. No heart disease, don't do echo. Don't order coronary artery calcium score for preoperative evaluation for any surgery, irrespective of patient risk. Don't initiate routine evaluation of carotid artery disease before cardiac surgery in the absence of symptoms or other high-risk criteria, only if the patient is symptomatic. Before cardiac surgery, there is no need for pulmonary function tests in the absence of respiratory symptoms. Do not obtain a preoperative chest X-ray in the absence of clinical suspicion for intrathoracic pathology. In a summary, surgery is an important therapeutic option for many older people. Preoperative assessment should be individualized, comprehensive, and often multidisciplinary. Attentive perioperative management minimize complication in older patients, especially those with chronic medical problems and functional impairment. Okay, that's it. Any question?
I think Arij has a question. Okay, Arij is asking, what about fear or stress in raising blood pressure? So I think it's very important to differentiate between hypertension due to stress and hypertension, which is primary or secondary, the true hypertension. I think the way you measure hypertension is going to define this one. So the most accurate way of measuring blood pressure is 24-hour ambulatory blood pressure. It will give you an estimate of whether the patient is hypertensive or not. And the second one is the hypertension that the patient measures at home once in the morning, once at the evening for 7 days. So when you measure the blood pressure in the clinic, for example, or in the operating room, the patient will automatically be hypertensive because of stress. I don't think this is going to change or affect the process of anesthesia or surgery. This is what I think, if anyone has any comment on this.
Yes, as I read also, it will not affect the surgery or anesthesia. It is common cause, as I said, pain can precipitate, it is stress. Urinary retention also can precipitate hypertension.
Fine.
Any comment?
Thank you so much for great presentation. And this is really to the point, and it's a big topic, but it is very important one when we see patients before they go to surgery, and then when we follow them after surgery. So the more we do before, we can prevent some of the post-operative complications or risk. Thank you so much.
You're welcome. Thank you. Then I can go to the questions if
we can skip the questions for now, but if we have time at the end of the meeting, we can go over them.
Okay.
Thank you.
You're welcome.
Okay, thank you very much, Dr. Hajar, Dr. Amal, for this great presentation. I have just a few comments on regarding the diabetes and operation or post and intraoperative and post-operative care. As we know that hyperglycemia during the operation is one of the well-known risk factors for many problems and complications related to surgery, like infection or delay in wound healing and a lot of problems. So the management of hyperglycemia intraoperative, mainly for patients who are uncontrolled diabetic, is really a big problem that facing clinicians. One of the known approach I saw in the slide here about talking about the sliding scale. Sliding scale might be used for patients who are well controlled, but for patients who are difficult controlled or with resistant hyperglycemia, I think this patient might need continuous intravenous infusion of insulin, and this will maintain an euglycemic state during the operation with frequent checkup that might need add-on sliding scale on top of this fixed dose of infusion, because this will maintain the euglycemia, which is very important to decrease the risk of complication related to the surgery in diabetic patient. That is what I would like to comment. Thank you very much for this great presentation, Dr. Amal, Dr. Hajar again. And our next presentation will be about how to write a letter to the editor, and the presenter will be Dr. Shayma Hassan. Let me just share the screen for Dr. Shayma, and she will take his role now.
Thank you, Dr. Rahman.
Okay, you can start.
Okay, hello everyone. This is Shayma Hassan. I'm talking today about the letter to the editor. What is a letter to the editor? You feel strongly about an issue and you want to let people know what you think. You believe you can even influence people to take some action if you speak your mind. But you want to reach an audience further than just your friend or your group membership. Letter to the editor can be an effective way to get the word out. A letter to the editor is a written way of talking newspaper, magazine, or other regular printed publication. Letter to the editor are generally found in the first section of the newspaper or towards the beginning of magazine or the editorial page. They can take a position for against an issue or simply inform both. They can convince reader by using emotion or fact, emotion and fact combined. Letter to the editor are usually short and tight, rarely larger than 300 words. Using few carefully placed letters, you can create plenty of community discussion. You can also keep an issue going by preventing it from disappearing from the public eye. You can stimulate the interest of the news media and create more cover from the matters you are working on. You can also send a good newsletter to bring recognition to people who deserve it or acknowledge the success of an effort. Why should you write a letter to the editor? Letter to the editor are among the most widely read features in any newspaper, magazine, or others. They allow you to reach large audience. You can probably think of many more specific reasons why you might want to write to the editor, but here are a few general ones. You are angry about something and want others to know it. You think that is an issue important that you have to speak out. Part of your group strategy is persuade to others to take specific action, or you want to suggest an idea to others, influence public opinion, educate in general public on the specific matter, publicize work of your group, and attract volunteer or program participants. How do you write a letter to the editor? Open the letter with a simple salutation. Letter to the editor start with a salutation, usually dear editor or dear sir, madam. Don't worry if you don't know the editor name. Simple to the editor of the Daily Sun, example, or just to the editor is sufficient. If you have the editor name, however, you should use it to increase the possibility of your letter being read. Grab the reader attention. Your opening sentence is very important. It should tell readers what you're writing about and make them want to read more. Explain what the letter is about at the start. Throughout your letter, remember the rule: be quick, be concise, and then be quiet. Don't make the editor or the general public wait to find out what you want to say. Tell them your key point at the beginning. Explain why the issue is important. If you are motivated enough to write a letter to the newspaper, magazine, the importance of your topic may seem clear to you. Remember that the general public probably doesn't share your background or the interest. Explain the issue and the importance simply. Use plain language that most people will understand. Give evidence for any praise or criticism. If you are writing a letter discussing past or pending action, be clear and showing why this will have a good or bad result. State your opinion about what should be done. You can write a letter just defend or to support, criticize a certain action or policy, but you may also have suggestions about what could be done to improve the situation. If so, be sure to add this as well. Be specific, and the more good reasons you can give to back up your your suggestion, the better. Sorry. Keep it brief. Generally, shorter letters have a better chance of being published. So go back over your letter and see if anything can be cut or condensed. If you have a lot to say and it can't be easily made short, you may want to check with the editor to see if could write longer opinion feature or guest column. Sign the letter. Be sure to write your full name and title if relevant, and include your address, phone number, and email address. Newspaper won't print anonymous letter, so in some case, they may withhold your name on request. They may also call you to confirm that you wrote the letter before they publish it. Check your letter to make sure it's clear and to the point. A newspaper may not print every letter it receives, but clear, well-written letters are likely to be given more serious consideration. How do you get your letter accepted? How likely your letter is to be published depends on certain extent on the publication you're sending it to. The New York Times probably receives hundreds, if not thousands, of letters a day. Only 10 or so which make it into print. A small town newspaper, on the other hand, may print every letter it gets, since it may get only 2 or 3 a day. Keep your letter under 300 words. Editors have a limited space for printing letter, and some papers have stated policies regarding length. Check the editorial page for this. Make sure your most important point are stated in the first paragraph. Editor may need to cut off your letter, and they usually do so from the bottom up. Refer to the recent event in your community or the recent article. Make a connection and make relevant. Use local statistics and personal stories to illustrate your point. Make sure you include your title as well as your name. It adds credibility, especially if it's relevant to the topic being discussed. If you are the program director, your title may lend credibility to the letter. Including your title is also important to showing that you're not trying to hide your interest in the topic. If you are program director and you don't mention that in your letter, there may be a letter the next day accusing of you dysfunction for not reviewing it. Editor may want to contact you, so include your phone number and email address. If your letter is not accepted the first time around, try again. You might submit with the revised version with a different angle on the issue at the later date. That's all for today. Thank you.
Thank you so much again, the question. This is great and concise and to the point. And I want just to share with you this sample letter. And this is from the New England Journal of Medicine. And before I talk about it, I just want to share with you a personal experience. When I moved from New Jersey, I did my first year there in residency. I moved to Lansing here. So on the second year of the class, when I joined, one of them was a resident who was interested in hematology and oncology. So in the beginning weeks, we were seeing patients and sometimes we discussed about research. And all of a sudden, I saw him talking about his accepted paper. So when we talk about it, he was mentioning it was only just a letter to the editor. So at that time, I figured out, oh, you don't have to do studies, you don't have to work hard to collect data and analysis and so forth to get publication. So one easier thing to do is writing a letter to the editor. But you have to identify your interest and then read more about the topic. And when there is an opportunity to write about the topic, and you will be an expert in that area, or at least you will go in that direction, then you will have a better picture, better ability to write the letter. When you become a specialist in this area, then also you will have the opportunity to write these letters to the editors. In this example that I'm showing you, this is about using surgery for essential tremor. And this is in reference to an article that was published in New England. So the three, I assume one of them at least is a surgeon, wrote this letter, and they refer the first sentence about the article that was published in New England Journal of Medicine. So they refer to that article and they discuss what they mentioned in that article. And then they showed their contribution, which is they want to add more approaches in their results. and then they supported that with some information about retrospective cases and so forth. So they mentioned their goal, they supported their goal, and then they, their last paragraph, they mentioned some of the limitations of one of the procedures, like they do surgery in this group. So this is how you do it. You, let's say you read an article and you want to write about it from your perspective. So you refer to that article, then you mention what's important that you want to add, and if you have any supporting information, and as always, if there is any limitation, you want to mention that. So this is somewhat easy to do, and greater chance to get it published properly. Thank you so much.
Thank you very much. Thank you very much, Dr. Nader. Okay. If any question to Dr. Nader?
If no questions, we can move on.
Okay, thank you, Dr. Nader. Our next topic will be about how to use Zootero app, and this presentation will be presented by Dr. Maha and me. So you are allowed to start now, Dr. Maha.
Hi, hello everyone. This is Maha. Let me share my screen. Sorry, it looks like I have privacy on my laptop. So Dr. Fatarman, I don't know if you can share the screen,
yes,
and
yes.
Then I
Okay.
read.
I will share.
It looks like I have privacy. I couldn't.
Okay, no problem.
Okay, hello everyone. Today I'm going to present using Zotero as reference management. Before starting my presentation, I want to bring your attention to that if you're working on a project like a research or a paper that needs citation, you're going to need Zotero as a reference manager. I believe some of you heard about EndNote or used it before. EndNote and Zotero do the same job, the same task. Both of them are reference manager, but the main difference between EndNote and Zotero is that EndNote is expensive software. You need to keep paying while using it. And by any chance, if you stopped paying, you're going to lose all the data or references that's saved to your account. So Zotero is more practical, easier, and you can have access to your references or information whenever you need. You're not going to lose it by any chance. In this presentation, we're going to talk about an overview, and then why do we need to use Zotero, and how to download and set up the software, how to add reference list, and how to add references with an identifier, and how to use Zotero connector. Basically, Zotero is a free, open source research tool. It helps you collect, organize, analyze the research, and share it in a variety of ways. It's in the most basic level, it's reference manager. It's designed to store, manage, cite bibliographic references such as books and articles. In the old way, people used to cite from articles and books and conference papers and write the citation in their main work in the research or the paper. And then at the end of the paper, they just mention the references manually. This way of writing references is very time consuming because you do it manually and it's likely to make tons of mistakes. Also, your reference list will be a mess. So Zotero came to just organize everything, organize your references and write it in a very professional way by itself. It's automatic. So when you go to articles or books or conference papers and cite, then Zotero will write down the references that you used in a very precise way. Next. Why do we need to use a reference management tool? First of all, it helps you manage your bibliographic resources and integrates with your word processing software to generate in-text citation and bibliographies. Zotero also helps you to keep track of your reading and references and makes it easier to find reference information to cite material in your work. It saves time and it improves the consistency and accuracy. As I mentioned before, Zotero is free. It's an open source reference management tool. It recognizes bibliographic information on books, journal articles, and other resources from websites and database, and extract metadata from these sources. It also stores related citations, PDFs, files, images, and links in your library. It creates a citation and bibliographies in Word or OpenOffice documents. It helps you publish and share libraries for your organizations, class, or research group. It's available for Mac, Windows, or Linux operating system. In the next slide, we're gonna learn how to download, how to set up Zotero. And then we're gonna explain step-by-step how can you start using it, how can you manage your references, import all the references to your Zotero, and then use it in your paper. First of all, if you go to Zootero.org, you're gonna click on the download button. I just want to mention that in the previous models, people used to say that Zotero works best with Firefox, but with the recent versions, it works with all kind of platforms without any problem. And next. If you after clicking on the download button, it's gonna take you to the version. The most recent version of Zotero is Zotero 6, and then make sure to use the platform that you're using. For example, if you're using Windows, you need to choose Zotero for Windows, and if it's for Mac, for Linux, it depends on the platform you're using. After downloading Zotero, you need to download Zotero connector because the connector helps you import the information from websites or whatever to your Zotero account. After clicking on the download, sometimes a message pop up saying the application you're trying to install isn't a verified app from the store, but you can install anyway. And then on the software, if the software is downloaded, the following slides will appear. It helps you, it takes you step by step to install the software. In this page, you can choose standard type and then next, then install, and then you finish installing and set up the software. This message confirms that you install Zotero, and then you go to download Zotero connector so your browser can save citations to Zotero. Next. Make sure that you click on Add Extension because this extension enables Zotero to sense bibliographic information on the web pages that you visit and allow you to save it to Zotero with a single click. Now, if you finish setup, setting the software, it's going to take you to the main page of Zotero. Note that this tool option, in the tool option, sometimes you can install the browser connector. For example, if you couldn't install Zotero connector from the beginning, you can wait till you install Zotero and then go to the tool, click on install browser connector, and then next. Then you will see the Z letter, the red Z letter in the taskbar displays Zotero. And this way you're going to have easy access to your Zotero. When you click on the Z bar, yeah, you're gonna, so you can access your Zotero software just with one click to the Z letter. Next. When you open the main Zotero page, you're gonna have 3 columns: left, middle, and right. In the left column, you're gonna see your library, which includes all your collections. In the middle column, you're gonna see information related to the selected library. And in the right column, you're gonna see information related to the items in the middle column. So the left column gives you the general subject or the general keyword. The middle column will include the references, and the right column will give you information about each reference in the middle column. Next. When you want to start adding information and organizing your Zotero account, you're gonna start with the left column. In the left column, you will see an icon saying new collection. In the far left. Then when you click on it, it's gonna open a box for you, so you can add your keyword or the subject or the main collection. For example, in our case, just to demonstrate, we're gonna choose diabetes and developing countries collection. It's our major subject for our paper, research, or whatever. You choose it and you save it down in your library. Then, in this page, I just put down the steps one more time in case some of you wants to go back and read the steps one more time. Now we're gonna start adding citations to Zotero. You can add citations to your library in several ways, either manually, import citation for a single item, import citation information for multiple items, automatically cite web page, or add items by identifier. When you want to add items manually, you start with your subject, the main collection in your library, for example, diabetes and developing countries, and then go to the middle column and choose a new item. As you see, if you click on this icon, it's gonna bring down some options like book section, document, journal article. What you choose, whatever the kind of reference you want to add. For example, if you're citing from a book, you're gonna choose book, and then another box will appear in the far right column, okay? And then you're gonna put down the information like the title, the author, the publisher, the publishing date, all these information related to the book you're gonna use for citation. Sometimes if you don't find your option, you can go to the more icon, and then it's gonna bring more options for you. Like if you wanna use like a conference paper, dictionary, document, email, whatever is the type, and then automatically you will find the fields related to that type of document. Here, we mentioned the steps one more time. Then we're gonna learn how to add items by identifier. I believe this is the favorite way, okay? So in the meta column, you can choose the icon that says add item by identifier. It's gonna open a box for you. Then you enter the ISBN or DOI or PMID, which is a PubMed ID. This number, you can find it in PubMed a website. If you choose any research from PubMed, you're going to find a small number in gray. You just copy it and paste it in this box. As you see in this slide, if you go to any research from PubMed, you're going to find a small number in gray. It's called PMID. You just copy it and paste it in Zotero in the box, and then automatically all the information will be imported to your account in Zotero. Now we're gonna learn how to add items from web sources. Before importing bibliographic data from web page to a specific Zotero collection, make sure that you're choosing the right collection so you can stay organized. If you're working on a specific subject like diabetes and developing countries, always make sure that you're in the right collection to stay organized. Also, I want to bring to your attention that you can save items to the same to Zotero collection using multiple web browsers like Firefox, Chrome, Safari at the same time, because the Zotero connector works in all these browsers. Now, if you display PubMed search results, okay, you go to PubMed, you write down the subject that you're working on. It's going to bring you a lot of results related to your subject. If you click to the Save to Zotero icon in the far right, it's going to bring up two things, two boxes. We're going to see in the next slide the two boxes that's going to show you after you click on Save to Zotero. The next page, you will see two boxes. The small box in your far left is going to show you the collection or the type of subject you're working on. So make sure you're in the right place. And then in the middle dialog box, you're going to see all the results from your search from PubMed. Then you choose the items that you want to import to Zotero. You can choose 1, 2, or all of them. The Zotero item selector dialog box and the saving to collection name box, which came up at the same time when you click Save to Zotero. And then the dialog box shows a list of all the records from the PubMed search result page. This example shows you the selected items in the list will be saved to the diabetes and developing countries collection because it was selected initially. As I mentioned, in this demonstration, we're going to choose only 3 items from PubMed search. If we click on OK, you're gonna the 3 items selected is in the Zotero item selector dialog box will import it to your Zotero. Finally, the 3 saved items are added to Zotero collection. In this slide, if you go back after saving everything, you can go back to your main page in Zotero to make sure that all the information you selected are already in the middle column. Because as I said, the middle column will show you the references that you're going to use. Remember, items of selected, if you go back, yeah, remember that items of a selected collection are listed in the middle column or panel of the Zotero collection. Bibliographic data of a selected items is shown in the right column. And then next, sometimes the icon that says Save to Zotero takes different shapes. For example, if you're looking at an journal article, the icon will look like a sheets. If you're looking to a book, the icon will look like a blue book. If you're looking at multiple items on a search result page like PubMed or Google Scholar, you're going to see the icon, the Save Zotero icon looks like Manila folder. Now to import citation for web pages into your Zotero collection, you're going to just right click on the Save to Zotero and then click Save to Zotero again, and then Save to Zotero web page without snapshot. After doing that, you're gonna go back to your Zotero main page to make sure that everything is imported. So you see WHO, World Health Organization, the website that you chose, and then in the right column, you have to write down manually the title, author, and date. Now next. In Zotero files, you can also, in Zotero, files can be attached to an item. You can add attachment to items by clicking on the paperclip button here. You can just click on here and attach any file you need to add to your Zotero. I believe Dr. Fathur Rahman will continue explaining about the software and how to use it.
Thank you very much, Dr. Maha, for this great presentation. Let me tell you that just 1 week ago, I didn't hear about this program, or even I have no idea. Me and I think many of you might just used to deal with maybe Mendeley EndNotes. For me, Zotero is a new program for me, but while I'm searching for it, I found this is a very good and very easy app that could be used for our researches. Let us just recap what Dr. Maha said. Initially, while we are doing a research, the first important thing is to manage our references, okay? After we collect our information and we get our references from either added it manually or using the PubMed identifier that mentioned previously, and I think this is a very good way for the presentation of the references. The next step will be how to organize the reference, how to add the bibliography on our research. So the first thing we are going to talk about is how to organize the references, how to make a collections, how to add tags, how to relate reference to each others. For example, if I'm talking about stomach cancer, I searched about it many times. If I have a research about this stomach cancer, for example, I will tag it and I will relate it to another reference I found, so I can relate them together. I can even tag a topic. And the last thing, how to add note to the reference, okay? So how to make a collection? I mean by collection, this is just as mentioned by Dr. Maha. If I have, for example, many researches, one of them is about a cancer, one of them is about diabetes, and so on. So I have to organize every resources with each other. So I have to make folders. So how to make the folders? Initially, we have to go for this. Let me just tag this. You have to select this icon to click on, and then you can add your new topics or new folders. And then let me show you. Yes, this icon will appear. Enter a name for the collection, and then you enter the topic you select, maybe diabetes, cancer, and so on. After that, if you look here, this is the cancer literature review. You even can subclassify into introduction, literature review, and so on. And then you can add the topics, okay? You click it and you put on this icon, then you will organize all of them together. This is really important for people who have many projects working on. This is how to collect your data. How to add tags? You will find on the right column here, tags appear, and then you go for add tag. Then you add your tag, for example, like this. The tag is cancer. So while you are searching for information for your research, and you find a topic related to the stomach cancer, then you tag, okay? After many researches and references, you will find that if you are looking for cancer or stomach cancer, just look for the tag, all of the researches will appear on the middle column. The third thing is how to add related references. Some references, they are related to other. You will find the icon related. You click on it, and then you add, you click OK, and then they will be added together. Also add notes. All of them, they are together, notes, tags, and related. You add notes, and you can add your comment, okay? This is the one of the best ways to organize our references in Zotero app. So the next topic we are going to talk about how to create a bibliography. And I think this is one of the very important things we are looking for while we are doing our researches. You are looking for how to put them together at the end of the research according to the style you choose. For example, this researcher has a lot of references in the middle column. As you look for this, all of them, they are researches, they are organized, and he's going to put them all together in a form of the maybe Vancouver or any other type. So how to do this? So to create a bibliography, first highlight the citations. To do this, hold down and control button on the keyboard and click on the individual citation in the middle column. Then create bibliography. Save as RTF. This is regarding the using in Word, Microsoft Word, or HTML if you are going to use it for websites. After saving, all of them, they are appear. And I think this is very impressive, or it's very nice to find them, all of them organized together with a very little work and exhaustion. So how to use Word or word processing integration? While we are writing our researches, usually we used to use Microsoft Word. So let us just look for the dashboard here. You will find Zotero. If you have Zotero app or program in your laptop, you will find it in this area, as I mentioned. And if you click on this, this box will appear. Add, edit, citation, sorry, bibliography, document preferences, and so on. So how to use it? This is the dashboard. And then it depends on the description or on the service you need. How to add a citation? You click just on add citation. For example, let us take this. To add a citation, put the cursor at the location in the text document where the citation will be placed and click on the Zotero add citation. For example, like this, you are going to add the citation in this area for these first sentences. After adding a citation, you add the page number and then click OK. You can add also several citations. This is the 3 citation for 3 boxes. Then this is the citation. The next thing is to add a bibliography. And as you see here, the bibliography appear on the last part of this section 1, 2, and 3. If you are going to edit a citation, also you can choose edit citation, and then you can even change the citation style you are using. We have a lot of citation style, which this depends on the journal you are applying for. Usually you will find this in instructions to authors, and then you will use their preference, and then you put the citation style according to the preference of the journal. This is the major issues we talk about. The last thing we are going to talk about is there is a service by Zotero, is called Zotero Groups, in which many individuals, they are sharing the same interests. They can share their work together, and this might be very helpful for them to collaborate their ideas together and to discover other people with similar interests. Thank you very much. If you have any questions, you are welcome to ask.
Thank you so much, both Dr. Hoffman and this is great. Thanks. Hopefully this will be a useful tool for all the fellows, and it will help you when you are collecting some of the references for any work that you do. It's going to be organized, as Dr. Hoffman mentioned, in collections or folders, and in the future you may need to go back, so it's going to be easier for you. And the good news is it's going to be like you can use it on your desktop, but it will be synchronized with the online account. So if you go to work and you have another computer there, you can access it while you are in your work or at a different place, for example. Thank you so much, both of you. Great presentation. Any questions? If no questions, then we can move on to the next agenda item.
Thank you very much, everyone. Thank you, Dr. Nader. So the last the presentation now is about using Google Sheets or Excel for analysis. Dr. Shaima.
Yes, Assalamu alaikum. How are you all? So now I'm going to present how to use Google Sheets and Excel for analysis, and specifically speak about Anova. So this is an overview. I will just go quickly what is Anova and what is a variance, why and when to use Anova, and if there's some rules on when to use it, how to calculate it manually, and what to do with our results, and if there are any shortcuts. It is, of course, Excel or the Google Sheet. So what is Anova? It just means analysis of variance, the first two letters of every word. It has an equation. We have the letter F, which signifies Anova as a result. It's just simply variance between groups divided by variance within each group. So what is variance? What is the groups we are talking about? So variance simply is a measure of variability from its names. And what is variability? We usually, in biostatistics, we use standard deviation to talk about variance. And what is standard deviation if we all forget about biostatistics? Standard deviation is simply subtracting each sample from the mean of a data and then squaring it. The higher standard deviation in a sample group or in a population, the higher the variability of this group. Variance, how is it related to standard deviation? Variance is simply the squaring of the standard deviation, and it also signifies the spread of numbers in a data set. So just a quick equation, what is variance? We take each sample, we subtract it from the mean, we square it, and then we add all these deductions from the mean, the square deductions from the mean, we all sum it all, and then we divide with the total number of data samples minus 1. So back again, what is Anova? It's analysis of this variance, and what is variance? It's the squaring of standard deviation. With standard deviation, it's just a measure of variation in a data relative to the mean. So a quick jump forward. When we calculate this F value, we will get 3 values. We will get the F ratio, which is our Anova. We will get something that is called F critical or F crit, and we will get a new calculated p-value. Usually we contrast this calculated p-value to our intended p-value, which goes by 0.05 in most cases, or 0.01. Also, if our F ratio, which is our Anova, is greater than our F critical, or if our calculated B value is smaller than the P value we want, then we can simply reject the H0 or the null hypothesis, as we spoke about the last time. So usually, what is our research question if we're talking about data that we want to calculate ANOVA for? We just want to see if there's statistical difference between the dependent and independent variables. So the null hypothesis can have many forms when we're talking about ANOVA, because ANOVA has many types. But all in all, when we say null hypothesis, then we mean that the mean is not affected by the variables in the data, and the variables themselves do not interact with each other. And of course, I will just go slowly over each of these. So most of us have taken the USMLE, and most of us remember this table from the UWorld. So we have something that's called dependent variable and something that is called independent variable. So the independent variable is, for example, we have a set of people and we are measuring their blood pressure. And we want to compare for example, their blood pressure in relative to their diet. So the independent variable we're talking about here is the diet. And we are assuming that according to their diet, which is independent, their blood pressure will differ. So the blood pressure is dependent on their diet. The types of data could be qualitative or categorical, which is male, female, heavy diet, fatty diet, or quantitative, which will have many numbers with decimals, like the blood pressure is quantitative. When we're talking about ANOVA or a t-test, we're talking about qualitative, categorical, independent variable, which will be here the diet. So diet A, diet B, diet C. And the blood pressure is a dependent variable, would be quantitative. So if we have qualitative independent and quantitative dependent, we can use t-test or ANOVA. Then when we use t-test and when we use ANOVA, we use t-test if we are comparing two populations, so population A and population B. So example, we have diet A or diet B. Then we will use the t-test to test for these two sets of data or two population samples. So what if we have many diets, many different diets we want to compare? Then we will use the ANOVA. So when we have 3 or more different samples, different populations, and they are categorical, independent data, then we will use the ANOVA test. So to use the ANOVA test, we have to have certain rules or assumptions for our data. Like I've just said, we have to have nominal data, which is what we just mentioned, categorical data. The data should be normally distributed or at least be sampled from a normally distributed population. We will assume that the data have similar variances, and when we say similar variances, we mean that the data group is said to be parametric, because if these rules are violated, we are having an unparametric data, and then we will use another test that is not ANOVA. So these rules are important to use ANOVA. And of course, we have to have independent samples unrelated to each others, and equal sample sizes are always preferred for ANOVA. We can violate it a little, but usually we need to have, for example, 100 patients tested for diet A, 100 for diet B, 100 for diet C, or similar sample size. So how many ANOVA types do we have? For simplicity, let's say 2 or 2+. We have something that's called one-way ANOVA or a single factor ANOVA, when we have one nominal data, which is the diet type. So this is one factor or one type. And we have two-way ANOVA when we have two nominal or two categorical variables. So not just the diet, maybe the diet and the calories. So we want to compare 2 things at a time. The two-way ANOVA have subgroups, which are with replication. And this is what we said about the uniform sample size. And without replication, when we have the same group, what we're gonna test it before, for example, suggesting for them diet type A, and after this diet we suggested, or the same group after diet A and after diet B. So with that replication, it's the same group. So what is a factor? It's our group of data, sets of data. For example, if we want to compare the reaction time of people when they drink different drinks. So example, we want to see the reaction time, is it faster with tea, coffee, or water? So we will have three groups, three independent data, but they all have this same title, which is drink. So this is a one factor. For this table, we're gonna use a one-way ANOVA. So what we have, what about we have, yeah, we have the drinks, but what we have another variable, which is the temperature of the tea, the temperature of the coffee, the temperature of the water. So now we have two nominal variables, the type of the drink and the temperature of the drink. For this, we were gonna use two-way ANOVA. And here we are assuming these are all different people. So we're used with two-way ANOVA with replication. I hope until now, everything is clear. So after we calculate the ANOVA, we will have this lovely picture of different calculations. We will first calculate mean of all data, mean of all groups. We will calculate something that is called a squared sum, the total squared sum, the data between the squared sum between the groups and within the groups. And then we will divide it by each other, and then we will square it, and then we calculate the ANOVA, which is the F value. So that's quite a long journey, right? After we calculated, our Excel or our Google Sheets will show us a table of summary of our data as a whole, their count in each group, the sum, the average, which is the mean, and their variance. And our ANOVA table will look like something like this. The SS, which is the sum of squares between groups and within groups, and total. And something that's called DF. DF stands for degree of freedom. MS or MQ, which is the mean squares, and our F critical, and our p-values that is calculated. So let's see one by one. So first, how to calculate the ANOVA? We calculate each of these data. First, we have the sum of squares. Let's say we have three sets of data, each will be just three values. And we want to calculate sum of squares. So we have something that is called total sum of squares. So from its name, the total sum of squares is that we assume all these three groups of data are just one long group of data. So we just put them on top of each other and manage them as if they are just one set. And we will calculate for them the total mean. So how to calculate the total mean? We'll just add them and divide them by the number, which is 9. And for each set of this data, we will deduct it from their mean. And then we will square it. And then we will add the square differences together. So this is what is called the total sum of squares. Again, we will get the mean of the total data. We will take the mean and subtract it from each of these data separately. And then we will square the deducted value. And then we will add them all together. What about the sum of squares within the groups? So we have each group, there will be variation between the data in each group. So 6, 7, 6, and 7, 5, 6, and 8, 7, 5, and 7. And of course, usually we have hundreds and thousands of data, not just 3. And of course, there will be variability within each group. So for example, for the T, there everybody will be different. So we'll have differences within each group. So we will calculate the sum of squares within the groups. How do we do that? We will similarly calculate the mean for this data. Again, deduct each data set from the mean, square it, and sum all the data together. So what about sum squares between the groups? We have variability between the groups. This group is different from this one, and this one is different from this one, and this one is different from this one. So we want to calculate the variability between the data sets. Again, we will do the same. We will take the total sum squares we calculated here, and we will take the means we calculated for each group and subtract the mean of this data from the total mean, the mean of this data from the total mean, and again, the mean of this data from the total mean. We will square the difference and we will add it. And this is the sum of squares between groups. So from its name, we will square the difference from the mean and we will add it together. So this is our first value that we just talked about, the SS. So what about the DF? We just talked about the SS, the sum of squares, and now we have the DF, the degree of freedom. So the degree of freedom is a straightforward equation. Between the groups, we will just take the total number of the groups, which in our case was 3 groups, and we'll subtract 1, and that's 2. So if we have 1,000 groups, we will subtract 1, it will be 999. So that's a straightforward equation. The same for within groups, but a different equation. We will take the total number of observation minus the total number of groups. So our observations, the total number is 3 plus 3 plus 3, and the total number of groups are just 3. So 9 minus 3 will be 6. So this is how we calculate the degree of freedom. So what about the third value, the MS or the MQ, which is the mean square? Here we want to take the average variation either between the groups or within the groups. Also, this is a straightforward equation. We will just divide the sum of squares divided by the degree of freedom, once for between the groups and once within the groups. So what about our F ratio? At last we came for our F ratio. It's simply division between the mean square of between groups divided by the mean square of within the groups. So we have many steps to reach our lovely F, our ANOVA result. And after we reach it, we have to compare our F value with our F critical. If our F value is larger than our F critical, and similarly, if our P value is smaller than 0.05, then we can reject the null value. How about this set of data? What do you think? Our F value is actually smaller than the F critical, so we can not reject the null hypothesis. We have to accept the null hypothesis. And our P value is so large, it's 0.5. It's much larger than 0.05. So this is also a P value that will make us will make us accept the null value. So back to our calculations, as you see, we calculated the mean value of all data, the mean values for the groups. We calculated the squared sum, the total of all data as a whole set between the groups and within the groups. And then we calculated the M squared. We divided the M squared between over within, and then we got our F ratio. So this is how we got this simple big table. So of course, not every time we want to calculate our ANOVA, we will go all these steps one by one. So that's why we have our Excel or Google Sheets. So what after we get our value? What after we get our F critical, like I've just said? Either our F is larger than our F critical, and similarly, at the same time, our calculated B should be smaller than or equal 0.05, and here we can safely reject our null hypothesis and say that the differences are statistically significant. So there is a sad fact about ANOVA, a backflash of this test, is that ANOVA will tell us there's some difference between the groups, but will never tell us which groups are different. So imagine that you're calculating a difference between 1,000 schools across your country, and you want to see the scores of students. Are they significantly different or not between the schools? So it will tell you, yes, there is a significant difference, but it will not tell you, is the significant difference between all the schools or just one from another, or just one from 2, or just one from 100, or how many differences are there? The Anova test will just tell you there is a difference, but it will not tell you which difference is there. So what do we do? After calculating ANOVA, we will need to do something that is called post-hoc analysis or post-hoc test. There are different tests we can do this we can do after we get our F value. There are different ones. The simplest is Bonferroni, we have Taki-Kramer, we have Holmes test. And if you have a small set of data, for example, up to 10 groups, you can apply multiple t-tests between each two groups. For example, if you have A, B, C, D, E, you can apply a t-test between A and B, then A and C, then A and E, then A and D, and then B and C, and then B and D, and then B and E for the different groups. Of course, it's easier to use one of the post-hoc analysis tests and not the multiple t-tests. It will take forever. So if there are any shortcuts, like we said, yes, we can use Excel and we can use Google Sheet. So they're similar yet different. For the Excel, you have first to go to Excel Home, File Home, and then Options. And after you click on the option, the screen will open. You will click on add-ins, and then you will click Manage, Excel Add-ins, and then Go. The screen will appear. These are already installed in our Excel. You don't need to download anything. You will just put a right click on Analysis Toolbar and click OK. That's all. And this is how we install the Anova equation in our Excel. What about Google Sheets? First, you will open the site docs.google.com/spreadsheets. It will open something like this. You will just click on a blank Google Sheet. Like last time, it's the same extension. We will click on extensions, add-on, and get add-ons if you don't have it. And usually, most of us don't have it. You will search for XL Minor Analysis Toolpack, and don't leave any spaces. If you leave a space between XL and Minor, it will not appear in the search. And install it. And after you install it, it will appear in the extensions down there. And you can click on XL Minor Analysis Toolpack and click Start. So this is the end, or not. Now let's go and take a trip to our Excel and our Google Sheets. Is my Excel viewing to all of you?
No.
I think you need to unshare and then share again.
No.
Okay, so I will share again. Now, can you see it?
Yes.
Okay, thank you. So we have a set of data. We have 3 types of detergents, A, B, and C, and we want to see the degree of whiteness after we wash these clothes with our detergent, with our different detergents. And this is a degree of whiteness. So we have 3 different data. So that's why we will use Anova. It's not 2. If it was 2, we will use 3 tests. If it's more 3, use this way: File, Options, Add-ins, Go, and you make sure that it's ticked right. And okay, then you will go to Data. And from Data, you will go to Data Analysis, the last tab here. And to show you this box, you will choose Anova, single factor, 2-factor, or 2-factor without replication. So what do you think we will use here? Single factor, or 2-factor with, or 2-factor without? So we are just having how many variables? You're just having the detergent, this is the independent, and the whiteness, this is the dependent. The detergent are categorical, they are called A, B, and C, and the whiteness, it's a value, so it's a quantitative data. So you'll use this Anova single factor because we are just comparing the whiteness and we don't have subgroups. So you will select our data. And now click OK. So for the input range, we will select our data, including the first column. And we will group the data by columns. If the data are arranged in rows, we'll use rows. Are there labels in our first row? Yes, I've selected A, B, and C. Our alpha is usually already submitted as 0.05. And then you want the output range here as output range or new worksheet or new workbook. So I'll just click here and click for a cell and okay. So again, here's Anova single factor. It's our summary. We have 3 groups, A, B, and C. We have our count in each data. So these are 9 sets of values for each group. They added all of them together. Then they calculated the mean for them, which is the average, and then they calculated the variance. For our Anova, this is the one we want. Sorry. We have between groups, we have within groups, we have total. It already calculated the sum of squares for us. We don't have to calculate the total for each one, and the between and within, it already calculated all of them. And similarly, calculated the degree of freedom. We said between groups, we have just number of groups minus 1. So 3 groups minus 1 is 2. And the within groups, we said the total number of data minus the degree, minus the number of groups. So 9 plus 9 plus 9, 9 times 3 equals 27, minus 3 equals 24. Then the mean squared, which is just dividing this by this. And then the F value, which is just dividing this by this. And then we have here our F factor, which is our Anova. It's 1.4. So what do we do with this value? We compare it with the F critical. So is it larger or smaller than our F critical? It's actually smaller. So it's not significant. We can also make sure by looking at our p-value. So our p-value is 0.25. Is this significant? No, it's larger than 0.05. So that's also not statistically significant. So what do you think about our null hypothesis and the alternative hypothesis? The null hypothesis, I'm sorry, I should have said it from the start, will be that there are no significant differences between the sets of data, and there is no interaction between the sets of data. This interaction part will be more evident in Anova, in the 2-factor Anova. And the alternative will be that there is at least one difference, one group difference between the sets of data. It could be between A and B, it could be between A and C, it could be between B and C, it could be between the 3 of them. So as we said, Anova doesn't tell us which groups are different. It just tells us if there is a difference at all or no difference at all. So since our F value here is smaller than the F critical and the P value is so large, it means there's no interaction and no statistical difference at all. What about the 2-way Anova? So again, we have the same set of data here, but I have subclassified the 3 sets of data according to the water temperature. So I've subclassified it using the detergent A, but with cold water, detergent A with warm water, and detergent A with hot water, and similarly for groups B and C. So here we have the detergents, and we have the degree of whiteness, but with subclassification cold, warm, and hot. So this is the difference. What do you think our null value will be? Our null hypothesis. On null hypothesis here, it can be more evident that there is no significant variation between the 3 groups of data and no interaction. So there is no interaction between this class, and this class, and similarly between each other. So no interaction within the groups and no interaction between the groups. And the alternative hypothesis will be that there is at least one difference or one variation in respect to our independent variable. So this is a 2-way Anova. This is with replication. Why is that with a replication? Because it's different sets of data. It's different pieces of clothes that are all white. We didn't take the same piece of clothes and use detergent A on it, and then B, and then C. No, these are totally different sets of data. They are not related. So let's again click on data analysis, and 2-way Anova with replication, and okay. We will select our input range, which is our data. How many rows per sample? So it's just asking about the subgroups. So we have 1, 2, 3 for each group. The cold has 3, the warm has 3, and the hot has 3. So we'll just enter 3. The alpha I will leave it the same and I will use an output range. Okay. So this time it made 3 big summaries for each class group. And then the total. And what we actually want is the ANOVA. So now the names of the columns or the rows, sorry, have changed. We have sample, column, interaction, and within. So the sample is simply our rows. Our rows are called samples. So this is cold, warm, and hot. And columns are just columns, A, B, and C. So is there interaction between them, and within each group there is variation. To calculate the SS for each one, the degree of freedom, the mean square, and our F value and our P value. So this P value is written in a weird way. It's written 3.50067E negative 05. So this E is actually means to the power of. A negative 05 means it's actually 0.0000 something, five zeros, and then 0.3. So the true way is that. So what about our V value? Our P value is so small, it's much smaller than 0.05. So for our samples, for our degree indifference between the samples called warm and hot, the P value is so small, so it's significant. Statistically significant variation and differences between our rows, our cold, warm, and hot. What about the columns? Is there a degree of variation statistically significant between detergents? Yes, it's smaller than 0.05. It's actually 0.001. So yeah, this is also statistically significant in the columns. So what about the interaction between each group and each other? There is statistically significant variance difference? Yes, there is. This is smaller than 0.05. It's 0.0004. So yes, there is a variance, statistically significant difference, an interaction between the groups. So the other way to do this, like I said, is to compare the F value with the F rate. 27 is larger than 3.8. So yes, there is a degree of variation, a statistically significant degree of variation between the rows. And the F value here, F ratio 16, is greater than 4. So yes, even between the detergent types, there is a variation. There is a statistically significant variation and difference. And between the interaction, F critical 15.9 is, of course, greater than 3.9. So for these, the F ratio is greater than the F critical, and the P value is also statistically significant since it's smaller than or equal 0.05. That's it for the word. Similarly, we can go for the Google Sheets. For Google Sheets, like we said, we have to make sure that we have our extension from add-on, get add-on. And XL Miner without spaces. And make sure you install it. I've already installed it. So it will appear on extensions, XL Miner, and start. For the sake of repetition, I've used a different data sets here. We have different drink types. And we want to see if the reaction time between these different people is statistically significantly different or not. So here, what do you think we will use ANOVA single factor or two factor with or without replication? We have just a single variable here, which is the degree, the type of the drink. And here we have the reaction time. So here the null value, the null hypothesis will be that the means of each of them are similar or there is not a statistically significant difference between them or variation. And the alternative hypothesis will be that there is at least one of them that is different from another one, different from all of them, different from 2 or 3 of them. We cannot know with just ANOVA, but it will tell us, yes, there is a difference. So after I clicked on that extension, it will open this screen for me. we will use Anova single factors since we're just comparing two different variables together. I will select the data and I will click on the input range. It will add it. The data is grouped again by columns. There is labels in the first row, yes. And the output range that I want, not this, I will choose this for the output range. And click OK. The same table again, the summary of all the groups, and Anova, SS, sum of squares, degree of freedom, MS mean squares, F our Anova or p-value, and F critical. So this is the table that I used in my presentation. So here the F value is much smaller than the F critical. So we cannot reject the null hypothesis. And the p-value is much larger than 0.05, so we cannot reject the null hypothesis. So here, we will not reject the null hypothesis, we will actually accept it, and we will reject the alternative. What about the Anova, two-factor Anova with replication? This is the same table I've used in Excel. The water temperature, cold, warm, and hot, degree of whiteness, and with different detergents. Null hypothesis, if there is no interaction between the detergent and water temperature on the degree of whiteness, and the alternative is there is some interaction. So again, here, extensions, start. Here we have two subgroups, one subgroup inside the variable. So here we are talking about two factors, two groups, not just one. Two dependent variables and not just one. So I'll use two-factor with replication. Why with replication? Can anybody answer me? Can anybody write in the chat why it's a two-factor with replication? I hope you all have not sleeping yet. Anybody awake can answer me? Hello?
So we have the three temperature. The water temperature,
yes.
three group. That's why it's two ways. And then there is no interaction, like not the same group we repeated. So it will be the replication. Thank you.
Yes, thank you, Dr. Nader. Yes, because there are three different groups. There are no interaction between each other. They are not the same type of cloths that we are washing again and again. So these are different. If we have the same, for example, group of clothes that we are using with A and B and C, we will actually use without replication because it's we are not repeating. Thank you. So again, I will select the data, the input range. The rows per sample, we said it's here in our example, it's 3. The alpha is always the same, and output range. Make sure the output range is just a single cell. And the input range should be not a single cell, so I will select my data again. And okay, oops, I have to make sure. Yep, now it's a range, so okay. So here again, it's made many summaries for each group. The error of XL minor analysis is that it will make the total. Here should be the group C and not the total, I think. And our Anova, again, we'll just expand it by clicking twice, not this much expansion. Okay. So here we have our F ratio, our p-value, and our F critical. We have just seen these values in our Excel sheet. So F critical, F ratio is bigger than F critical for the samples, which are here, the degree of temperature of the water. which were in the rows, if you remember. In the rows, we have the degree of water temperature, and the columns is the detergent. So there is a difference in the sample and a difference in the columns, which is a detergent. And the interaction between them, yes, there is an interaction between them. The p-values is significant for all because 0.0000 for all of them, smaller than 0.05. So again, we can safely reject the null hypothesis and say that yes, there is at least one difference in the effect of water temperature and whiteness. It will affect the degree of whiteness, for the detergent. Not just the degree of water temperature. Here is the rows. So the rows is the water temperature. And for the columns, it will be the detergent types. So at least it has separated them by rows and columns so that you know the water temperature effect on the whiteness is significant, and the detergent type effect on the whiteness is significant, and the interaction between them is also significant. So what do we do with these values? We will have to do a post-hoc analysis like Poincaré to see which groups are different. Is it A with B, A with C, B with C, or all of them? That's it. Thank you for today.
Thank you so much. This is another great presentation. Excellent. Thank you for going over and with some details and demonstrations. So it's very good visual for all of us. Thanks.
You're welcome.
Any questions for Dr. Nurhan or any of the other speakers? I think we did great. I think all of you did excellent job. And now we can go to the next item section. I know we went over to our finish for the meeting, but we will spend a few minutes just talking about the projects, and then for next meeting. So any updates for current projects or ideas, please raise your hand or something. Let us know. Thank you. Dr. Patron, go ahead.
I have a proposal, two proposals for research projects, and I would just like your opinion and advice on them.
Sounds good.
One is like the efficacy of methylene blue in treating Alzheimer, and the other is the efficacy of CBD as an antipsychotic in the elderly.
Sounds good. So shoot me an email, and then we can see what the next step as far as what we need to do about these two ideas. Thank you so much.
Okay.
Yeah.
Okay, thank you.
Yeah. Excellent. Any other ideas or updates?
I have an idea, Dr. Nadim, that we didn't start on it till now, about the association between obstructive sleep apnea and progression of Alzheimer's disease.
Sounds good. So also if you can shoot me an email, and we can see what the next step, what we can do. Excellent. Good idea.
Okay, inshallah. Thank you.
Great ideas. Any other ideas or research questions that you might have? Or maybe the update about the current projects? I know next week there are 3 abstracts that will be presented or posted at the AAIC, which is our Alzheimer's meeting. If I'm not mistaken, but also virtual. So some of the group will be presenting virtually, which is good. Anything about other projects, current projects that any one of you want to add to? If you can send me an email later with any questions or updates, and then we will take it from there. So for the next meeting, I'm gonna just share my screen. So thank you everyone for attending, and thank you all the presenters for today, and Dr. Rahman for monitoring or opening this meeting. For next meeting, the green team will be presenting. So I added some information here with names. If the team leader can reach out to all these group members and then see if any one of them can participate, even if it's with part of the presentation similar to what we did today. They can divide the presentation of the report between 2 or 3. Tell us, that would be great. If no other questions, let's see the chat. Then I'd like to thank you all for attending, for your time and effort. Thank you for a great presentation. All the fellows that presented today was great. If anything, let me know. I wish you all the best, and we'll see you next week. Okay, have on today or night. And great.
Thank you, Dr. Nader.
Thank you, everyone. I will be waiting for one of the group to discuss one of the topics at the end of this meeting. So for the rest, I wish you all the best. Thank you. Bye-bye.
Thank you, Dr. Nader, and have a good night.
Good night. Have a good day.
Thank you so much.
Thank you, Dr. Nader.
Thank you.
Thank you, Dr. Nader.
Thank you so much, Dr. Nader. Salaam.
Thank you, Dr.
Thank you.
Thank you, Dr. Nader.
Thank you, everyone. So, Shushma, if you are still with us, you have a minute, we can go over the table of the project. Actually, the person is not in today, the fellow. So I wish you all the best, guys. If you have questions, let me know.
Dr. Nader. Hello?
Hello, yes, go ahead.
Yeah.
Yes,
I want to ask you a question.
Yes.
I started a project research by myself.
Mm-hmm.
I'm not sure if it's accepted to do it with geriatric fellowship because it's not in the geriatric population. It's about vitamin D, effect of vitamin D in diabetes. And I took both type 1 and type 2 diabetes.
Mm-hmm.
I collected all the data and I wrote the introduction and half of the discussion.
Mm-hmm.
I don't know, is it okay to do it?
Yeah. Some of the project might not be related directly to geriatric. So as long as you are working on a research project and as long as you apply whatever we are learning in this fellowship, I think it's a good idea. The idea is to teach you the skills and see how you can apply it. And hopefully when you start the residency, you can be able to do any type of research down the road. So whatever you can do now, I think it will be very helpful. And if you need, maybe if you are open to the idea of working in a team, you can ask them of the fellow interested in the topic that may help you out, and then you can.
Yeah, okay, great. Actually, I did about more than half of it. Maybe if some people want to finish it.
Yeah, and then you can identify which area. If it's a paper, which journal, if it's
and is it okay to publish it, to submit it into Curious? It is a literature review.
So Curious, yeah. Yeah.
Okay.
So see who is interested from the group, and then make a team and identify back and assign them, and hopefully you can submit it and be accepted.
Okay, great. Thank you so much.
Thank you. Thank you for sharing this idea. And, good luck with the
okay, thank you. Thank you so much. Assalamu alaikum.
And I'll start the session. If not, I will see you next week. Assalamu alaikum.
Yeah,